Yeah, Assalamu alaikum wa rahmatullah. Today, the topic which we will going to discuss is perioperative medicine. Okay. So, may I ask anyone has heard about this word perioperative physician or perioperative medicine before?
Assalamu alaikum.
Walaikum assalam.
Okay, this, uh,
Yes, Dr.
yeah,
Nawaz.
there are fellowships in perioperative medicine I have seen, but what I think about perioperative medicine is if you do perioperative medicine, you will be confined to the like doing assessments and preoperatively or optimizing them or what. I don't know what we'll do after doing this fellowship. There is fellowship in perioperative medicine.
Okay, actually, perioperative medicine, the fellowship which you are talking about is a little bit different than this topic as a whole. Okay, because actually anesthetist is not only anesthetist is actually in virtual sense, because anesthesia means only making the patient sleep or getting the patient awake. Okay, so but actually anesthesia is beyond that thing. Anesthesia is not doing only this thing. Actually he is doing a lot more than this. Okay, so the concept of perioperative medicine is that anesthetist should be involved in any decision making in management, not only from the preoperative period, and any decision about the surgery unless the surgery is urgent or unless the surgery is deemed necessary declared by the surgeons. The decision making should be mutually taken, and it should not be taken as that anesthetist is being taken like the word which we listen from the surgeons. Just I want a small sedation. Okay, and he is not thinking about anything else. So our role as perioperative physician is that we should be involved in overall management and the outcome of the patient rather than only focusing on the just mere giving anesthesia. So this is the basic concept. And actually, when we talk about perioperative medicine, there are certain things which are actually in related to it. Okay, for example, thorough preoperative evaluation. Like you said about preoperative evaluation. Okay, so preoperative evaluation should be focused in the sense that you should be targeting what are the risk factors, what what is the margin of optimization. Okay, and like of course a big thing will be the surgical urgency, like surgery itself with reference to its urgency, because whatever you want to do you cannot do unless you have some time. Like for example, if a surgery is deemed necessary and you cannot delay the procedure, so the optimization, you cannot have a number of things which you can get when you have more time. Okay, so the concept of perioperative medicine is that the anesthetist should be involved in the whole management, overall management of the patient. Okay, so this is the basic concept. And there are certain protocols which are being used with reference to conduct of this thing, because one of the thing which is like recently it was started with the colorectal surgery and orthopedic surgeries, joint arthroplasties, and now that thing is now there in a number of other surgeries, that is ERAS, enhanced recovery after surgery. So this is one of the thing in which uh, anesthetist is being involved in the throughout management of the patient, and it is focused toward better outcome. And the basic theory is that you are supposed to reduce the hospital stay. So that's why day surgery is also, you can say, one of the targets in which the outcome will be improved. Day surgery, then uh, part and parcel of this thing will be when you are trying to have day surgery or ERAS protocol, that will be opioid free anesthesia. Okay, opioid free anesthesia. is one of the thing, because usually like if you are able to plan, chalk out some things which are focused on better outcome, rather than just only that's the word which I use, that only giving anesthesia is nothing. The anesthetist should be involved in the whole package, from the pre-op to the post-op. Okay, so that is the main concept. And there are like recently there was a anesthesia tutorial which came with the with this title of perioperative medicine. A number of things which we are doing in bits and pieces, and but this is a theory in which you are fully involved. And I gave an example for that thing, that recently I had a case which was only conducting an MRI, okay, MRI for a patient which had a syndrome in which like pediatric age group has like uncontrolled body weight, okay, and the patient which I had weight of around 70 kg at age of 5 years, okay. So maybe I fault in the spelling. It's Prader-Willi syndrome. Okay, Prader-Willi syndrome, something like that. Maybe spellings, maybe a little mistake. And the main, there are metabolic problems which are related to uncontrolled hunger. The baby is eating a lot and gaining weight. Okay, so that baby was 5 years and the weight was 70 kg. Okay, and that patient came only for MRI, which should not, would not have changed any management plan. Okay, because usually these babies, when they are slightly optimized, they undergo bariatric surgeries and try to have something to reduce the weight and improve the quality of life, usually whatever, like. So MRI at age of 5 years would not have changed much of the management. But what was the problem? That there was no connection between the primary pediatrician who advised, ICU doctor, radiology, and the anesthetist. Okay, so this is a like a pilot case in which you can say that there was very too much importance of the anesthetist, but unfortunately this thing was not discussed. The patient went for preoperative clearance. Actually, the anesthetist who saw the patient in the clinic tried to convince that this will be a very dangerous thing, but because the pediatrician, there was not much of the communication between the anesthetist and the pediatrician. So what happened? They underwent the procedure. I gave the anesthesia. Only if the procedure was lasting for 15 to 20 minutes. And can you believe this? As it was expected, the patient remained intubated for 12 days. Okay. So this was lack of application of perioperative medicine. Like, they were not interested about the risk versus benefits, and anesthetist, mainly the anesthetist, was not involved in the decision making. Okay, so the result was a very bad outcome, and maybe that patient would have ended up in having tracheostomy. So this, I'm giving you one example. There are so many examples which you can chalk out. Another example I will give, that because I am giving you practical examples which actually I face every now and then, and the lack is, again, there is no coordination, there is no multidisciplinary involvement. And again, because I say that anesthetists give the care like a mother, and the surgeon are actually like father. So fathers are actually a little bit casual. They are not as meticulous as mothers. So actually, the role of anesthetist in the operation theater is like mother. He has to think about everything. So he should be involved in the decision making. Unfortunately, it's never done like that. Unfortunately, even in very good centers like I'm working. So it's the problem is that there is lack of decision. So I'm just giving another example. A patient who is booked for tonsillectomy, okay, adenotonsillectomy, and uh, this patient is also coming for dental rehabilitation. Okay, So because if for example anesthetist will be involved in decision making of this patient, so dental rehabilitation is not the priority. This adenotonsillectomy is a priority, and this should be done before dental rehabilitation. But because of the logistic problems and a number of things, they actually a number, like I saw number of times these patients are coming for babies like 4 to 3 to like you can say between age of 3 to 5 or 6 years. Okay, so these patients are at risk of, especially with adenotonsillectomy, these patients are at risk of OSA, pediatric OSA. Okay, so and then another thing, if this patient is coming for dental procedure rehabilitation first, usually in these procedures they are asking for nasal endotracheal tube. Okay, so like endotracheal intubation in a patient who has adenoids, it's not safe, unfortunately, and like a number of times this will be missed, and this can create problems. So if anesthetist is been involved, definitely he would ask for two things: either this procedure should be done first, or they can have a combined together. They can do this procedure together with adenotoxectomy first, and then they can do the dental rehabilitation. So I'm just giving you few examples. There you can find, if you think, you will find
Mustafa,
so many, you will
I
find
can.
so you will find so many examples in which you can apply this thing. Okay, so like coming back to the text with reference to this article, so the message which is to be given to all of my friends, whether you are junior or senior or whoever, please try to think in that way. Try to think in that way, that may because our role starts from preoperative evaluation. Unfortunately, whenever we send the patient for even for a referral, we just write cardiac evaluation. We don't know what we want from that cardiac evaluation. We should be very focused, and we should be very clear what will that cardiac evaluation tell us. Okay, risk stratification is one of them. Okay, but if the surgical procedure is urgent, for example like cancer patient or any surgery which cannot be delayed for a certain period of time, unfortunately this cardiac evaluation will not change the management. So our aim at that moment is actually mainly a number of times we just want to cover ourselves medical legally, number one, and that only we are just trying to have the what are the risk involved. Okay, so in that way we will be able to handle this patient with more care, with invasive monitoring, with invasive lines, post-operative ICU. Okay, ICU handling, and now the role as perioperative physician is that we should discuss this with the surgeon, that how much time we can get with that patient. Okay, like how much time we have for the optimization of the patient, number one. Number two, our role will be to get involved to try to have a minimum invasive procedure. Okay, so this will be one of the thing which is in which our role should be there. Okay, so similarly whatever optimization we can do in that certain period of time, we should focus. So this is, I'm giving you one example. Okay, so other way around, if you have an elective case, totally elective case, you would like to fix the problem, like you would like to control the hypertension, or you would like to have maximum control of the cardiac failure. Okay, or for example in case there is ischemic heart disease in an elective patient, that will take the priority. Maybe if the patient is coming for a bariatric surgery or joint replacement, and the same time the patient has active cardiac condition, or not really active cardiac condition, the patient undergoes cardiac evaluation and founds to have some event or some element of ischemia. Now the elective surgery should not be done before the cardiac intervention. So you have to think, and again we should have the driving seat, the driving role in this decision making. Okay, So this is the concept you should be focusing. Of course, in certain conditions you will not have this liberty, but still, like you can do a lot of things. Like for example, if there is a good anesthetist and now he's handling a patient with some cardiac problem. Okay, so the preoperative, in addition to the preoperative evaluation, whatever he has done, if he cannot get a proper echo done, a few things he can get with a simple use of ultrasound. Like he can see whether the patient's lungs are wet. If of course this needs training, but if you are good enough, you can have like any like B lines. I'm not very like expert in that thing, but there are certain findings which you can get in the lungs with one thing. Then you can put the probe in the epigastrium, and you can see the vena cava compressibility. This will tell you the volume status, if the patient is overloaded or not. Okay, because of course chest X-ray will tell that, but chest X-ray may not be that much accurate if the patient is not mobile. If the patient is on the bed, the actually chest X-ray will not tell you that good information as compared. So the what will be the result, that you will be able to handle this patient in a better way, that whether this patient need inotrope, whether this patient need vasopressor, whether this patient need fluid. Because a number of times actually we are keeping the patient too dry, that like actually if still there is vena cava compressibility, maybe still you can give some fluid instead of just hitting the heart with inotropes. Okay, so this is the theory. This is the role of I'm telling you. So and you can utilize this theory in a number of things. Like you are handling any patient, so you should be thinking any optimization, any valuation which you can get even in a quick time. Okay, so this is just background, and we will just now try to have on look. So perioperative medicine is an evolving field that focuses on optimizing the care of surgical patient from the contemplation of surgery until fully recover. Okay, its successful implementation depends on collaboration between several hospital community-based disciplines. From within the hospital, this is often led by the anesthesiologist, given their expertise in preoperative assessment. Okay, so we have to identify how is the heart, how is the liver, how are the kidneys, how is the brain, how is the like any and other risks. Like we have to quantify all the risk, like whatever anesthesia steps we will be following, we should be focusing or our preoperative, that this patient is how much is risk with the airway management, how much is the risk with post-operative nausea vomiting, how much is risk for aspiration. So these things should be in our focus. Okay, it's because if we don't have this focus, unfortunately a proper plan will not be chalked out, and this will result in bad outcomes. So like another thing which comes here is that if for example in a number of cases you are asked to give hypotensive anesthesia. Okay, and you did not chalk out a good plan, and now the surgeon is asking, because surgeon does not know anything, surgeon is asking the number, and you did not thoroughly evaluate the patient, and the patient baseline blood pressure was quite high, and now you try to bring hypertension and the surgery remains for 5 hours. That like one example is shoulder surgery, for example. And so if you are doing a shoulder surgery and in a sitting position, and now you give hypotensive anesthesia for 5 hours, 4 hours, the patient will result in ischemia. Okay, so this should be in your mind, that you should plan things what are the allowable things and what are not allowable things. Okay, so coming back, so the goals of perioperative medicines are to provide care that identifies and optimizes medical comorbidities before surgery, adds value at each patient contact to reduce complication and hospital length of stay, strives to target improve patient experience, satisfaction, or outcome of surgery. Okay, so because the patient will be so you have to explain all the things to the patient. One important finding here will be this concept of brand. Okay, so benefits, risk, alternatives to treatment, and consider the prognosis with no treatment. Okay, so what will be the advantage of doing anything? So like in this should be very clear when you are doing a pre-operative assessment. Okay, and you should have right to say no, that this will not be beneficial. Like when we discuss this, some things, a number of points you can discuss, but unfortunately, this concept is not acceptable by the surgeons even in best of the centers. So this is the problem. But now they are gradually they are coming to this point, and they are trying to apply this more and more. Okay, so there should be a meeting in which multidisciplines, the patient and surgeon should be involved, and then they should be deciding what is the best patient management. Okay, so same thing they have written here, starting when the surgery is suggested, continuing at every step along the surgical journey. Okay, so then you have to identify everything. Like usually what we think is, for example, smoking, control of blood pressure, control of blood sugar, correction of anemia, smoking, okay, and incentive spirometry, correction of heart failure, correction of this one, any, for example, if patient with COPD, you should target the reversible component of the bronchospasm. You can have antibiotics, you can have incentive spirometry, you can have chest physiotherapy, you can have drainage of pleural effusion, you can have some treatment of the heart failure. Okay, so these things will be they should be in your mind, and you will do the things according to the time you have. Like if you have a patient with anemia coming for an elective surgery, you are supposed to correct the anemia with either IV or oral according to the situation, or you will try to build up, or you will try to go for the blood conservative strategies if the surgery is urgent. So you will be giving hypotensive anesthesia, you can have you role of a number of things, cell saver. So this thing you will be deciding when you are evaluating the patient in the preoperative period. Okay, so this is then with reference to physical activity. You will see shortly the Duke activity index. You see if the patient has physical activity, you have to quantify according to the, like, either New York Heart Association classification for heart failure, or Canadian class of angina. Okay, so with these, and there are some other test with reference to like CPEX. There is a recently test which is not available in all centers, cardiopulmonary exercise testing, in which actually you are looking at the cardiopulmonary reserve. Okay, so so this will be with reference to cardiac. Similarly, you will find a number of things with reference to all systems, like pulmonary functions. How are the pulmonary functions? How is the mechanical functions of the respiratory system? How is the gas exchange going on? So you will have certain criteria by which you can label it as risk. So if the patient, for example, low albumin, you find because of any reason, maybe because of liver dysfunction, now you have patient with albumin, low albumin, this patient is at more risk to develop pulmonary edema because there is less oncotic pressure, and the patient can go. So this is you, if you are chalking out pulmonary risk factors, so smoking is one of them, low albumin is one of them. Upper abdominal surgery is one of them. Any surgery in which thoracic or abdominal surgery. So, like, you will be focusing on stratifying and quantifying the risk involved in all systems: renal risk, pulmonary risk, cardiac risk. I have discussed these things a number of times before, and because this is a whole anesthesia, believe me, if you focus this thing and fit these points in whatever disease you are studying and whatever topic you are preparing or whatever surgery you are preparing, believe me, your anesthesia management will be totally different from what you are doing because your focus will be changed. So I highly recommend you to use these points in whatever. Of course, you will have limitations, but you will have a lot of things you can do. Okay. So similarly, with reference to this, there will be a perioperative team with anesthetist as the central role, and they did some survey in UK, and as Like, in fact, perioperative medicine can be delivered by the specialists in other disciplines, and any service that establishes effective work stream among healthcare professionals with a shared focus on patient outcome can participate in perioperative medicine delivery. Okay, as the patient progresses through the healthcare system, the clinical governance of the care may shift between various specialties. So the basic concept is, of course, the anesthetist will be the main, but there will be participation from other specialties. Okay, so this is one thing. Then bundled care. Bundled care, we have heard about a number of bundles, ICU bundles, and etc. 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 So actually, IRAS is the future. IRAS management will be there in all this, and actually, they have you will find articles for IRAS in every surgery. Almost IRAS for cesarean section, IRAS for colorectal surgery, and orthopedic was this first one, and now they are trying to have IRAS with everything. Like, for example, even thoracic surgery now they are trying to do with VATS, and with the VATS, actually the outcome of the patient is totally changed. Video assisted thoracoscopic surgery. So similarly, you will find a number of things which are changed now. They are doing like arthroscopic surgeries. So arthroscopic surgery, there will be less tissue trauma, so the outcome will be better. Okay, so similarly, so this will be one thing. Then they will try to have from anesthesia the use of opiate-free anesthesia. I am a big advocate of opiate-free anesthesia, and actually, I'm trying to like minimize, or actually, I have almost deleted the use of opioids in my anesthesia management, and I'm using alternative medication with ketamine and Presidex and lidocaine and like multimodal analgesia, with main focus on the things which are the basic analgesics, like paracetamol, NSAIDs, use of lidocaine. Ketamine is an excellent medication, with dexmedetomidine is an excellent choice, and then use of local infiltration, even use of, like, for example, if you are performing cystoscopy, okay, cystoscopy for a very simple procedure, even you have given GA, even then with general anesthesia, it is better. It is better that you ask them to have proper lubrication of jelly before they put, because usually what they do, they just put the jelly and they are just using it as lubricant rather than local anesthetic. If you want to have that the response, surgical response is minimized, you should request them to put the jelly and wait for few seconds, at least for 1 minute, rather than just putting the jelly and then starting. And same principle will be there with endoscopies. Endoscopies, if you are working in endoscopy and they are doing this procedure, don't let them start the procedure until local anesthetic has taken the effect. Then similarly with this small point, you can request the surgeon to, even if you have not given a block, if you can give a block, okay, fine. Otherwise, the minimum you can do is to, for example, whatever place they are giving the NCN, request them to use lidocaine in the line where they have to give the NCN. I know that this will be a difficult thing, and this is our part as perioperative physician over there. This is not anesthesia job, because they will say that patient is having GA. I'm listening this thing and I'm trying to teach them very softly and requesting them, but number of times they say, why? We will give it at the end of the surgery. Okay, fine. You can give it at the end of the surgery, but the role will be that will be for the post-operative period. The advantage of giving the local anesthesia at that time before giving NCN is like you cannot discard this role, because the stress response will be reduced, the change in heart rate will be reduced, and actually, if you want to see how good your anesthesia is, just try to have the response to the NCN. If you don't have much, like up to 20% of the baseline will be fine, but if you are getting more than that, it means your anesthesia is not adequate. And actually, we do it in a different way. We have given fentanyl and we give another dose of fentanyl at that time. Or some people will increase the dial concentration, or some people will do a number of things. But there is no replacement to the thing which I am telling you, because other things which you will do, suddenly the blood pressure will fall down. and then you are giving vasopressor. So you are in a vicious cycle. So if you want the things to be in stable condition, try the use of multimodal analgesia. This is an excellent approach. Like, give analgesia before you start, before they prick, before you poke. Try to have analgesia in the blood. Give paracetamol, give NSAID, like the role of preemptive analgesia. I have discussed this thing a number of times. I'm just touching wherever it is important. Okay. So the same things which I have already told you, the same things they are telling here. An important thing is with reference to frailty. So frailty actually is the like uh, like the patient is not feeling good, or the patient is not in good condition. Not only aging, but it can be in other condition as well. And another very important thing will be with reference to nutrition. So frailty, there is a very frailty score which they are focusing, and one of them will be the nutrition. Okay, so nutrition is very important, and unfortunately number of times we don't focus on this very important aspect. Okay, so malnutrition is one of the factor for bad, because it will result in a bad outcome. Okay, so whenever possible, you should be focusing on the nutritional elements as well. Okay, so these are some of the tests I was telling you about it. Unfortunately, it's in the upright direction, but it is Duke Activity Index with reference to physical activity. Cardiopulmonary exercising test is also the same. 6-minute walk test is also another same thing. Time up and go time. This is like, of course, we don't do it a number of times, but they are saying 5 sit to stand test. Okay, they're asking to stand for 5 times to see the activity level. Okay. Uh, Similarly, these are some variables with reference to risk. So P POSUM is one of them. In this discussion we cannot discuss about the details. I will share you the article, and you can have a look at it. Okay. Similarly, prehabilitation. Prehabilitation is actually the same thing which we use with the word of optimization, but actually this prehabilitation, that you are trying to motivate, or you are trying to anticipate for the thing which will happen. So these will be like from the promoting physical activity, smoking cessation, reducing alcohol consumption, optimizing nutritional status. Okay. Of course, it will be according to the surgery. If the surgery is urgent, you cannot do these things, but still there will be a number of things which you can do, as I told you, incentive spirometry is one of the things. Okay, so similarly in post-operative period, they are having this acronym of DREAM. Okay, so drinking, eating, and mobilizing within 24 hours of surgery. So this is DREAM. So they are trying to minimize the not only the NPO period, the post-operatively also. And this can happen only if you are not using much of opiates, because opiates are a big factor for post-operative nausea vomiting. Opiates is a big factor for ileus. I'll give you one example. If you have a patient in post-operative period having ileus, and now there is pain because of the stretch, the patient is having ileus, the patient is having pain, the patient is complaining of pain, and the resident over there is giving more morphine. So this is becoming a vicious cycle. So if you want to break this vicious cycle, you have to come out of it. You will try to have some alternatives. You will try to correct the electrolyte imbalance. You will try to give a very good fluid balance, because fluid balance people forget, unfortunately, because we are always afraid patient will go on overload. Patient will go in overload. How many times you have ever seen? I am giving anesthesia for 19 years. I have never seen a patient going in overload, a normal patient, because if you drink five glasses of water, after half an hour you will go to the bathroom. So similar will happen here. If you have given a little more of fluid and the kidney is functioning nicely, patient will produce urine, and that's it. So why are you afraid? In this way, actually, we are depriving the patients of the fluid, and this result in poor wound healing. This is a risk factor for poor perfusion and problems. If there are certain more risk factors, there will be more chances of wound infection. And actually, surgeon doesn't know about it. That patient is vomiting later on more post-operatively, because you have given a lot of opioids and you have not given adequate fluid, and there is electrolyte imbalance, and there is chances of ileus, and that you are in a vicious cycle. Okay, so remember these things. These things are very important there, because there are so many things which you can find out in every surgery. Okay, but I'm just giving you a taste. This is, you can say, another kabila, another thought, because we think intubation, sevoflurane, isoflurane. Thank you very much. Give, if you are in low socioeconomics centers, you are giving nalbuphine, and if you are in a good centers, you are using morphine, fentanyl. Thank you very much. Reverse with neostigmine, and you are forgetting that if you are reversing with neostigmine, there are more chances of nausea vomiting. So whenever possible, yes, there will be problems with recently, there was a case report of Sugammadex anaphylaxis. But whenever Sugammadex is available, that's the best of the best choice, because you will avoid any, because neostigmine, you are giving glycopyrrolate patient. Even if you are giving glycopyrrolate, there will be some tachycardia. Still, even with glycopyrrolate, yes, less than atropine, but actually you are giving medications which are affecting the heart. In whatever possible way, you are increasing the secretions. You are like creating a lot of problems. So, like, I'm giving you an insight. Of course, not everyone will have this flexibility of availability of very good medications alternative, but the message should be clear. Try to avoid, minimize whatever you can, whatever is in your hands. Okay. So, similar, like, so these were the basic points. There was one, actually, they did a trial. uh, this one, I will finish in few minutes. This was the one. Okay, this article is based on key findings and recommendation from the Getting It Right First Time. This was some national report of perioperative medicine, and outlines key concept of perioperative medicine. They did. Okay, and then they published, or they advised some things. So with reference to all of these things we have already discussed and done, I will just quickly go through it and then we will finish. Assessment, advice, and support on how to improve general health and underlying health conditions, and individualized preoperative assessment with information on benefits, risk, and alternatives to the surgery. The word which we brand which we used. Okay, and then screening for conditions known to increase risk of adverse postoperative outcomes, frailty, or chronic pain, with access to specialist services and support. Yes, one thing I did not mention, like one of the most important factor for you as anesthetist is to find out the patient who are at risk of chronic post-surgical pain. Okay, so this is very important thing. So if the patient is at risk of chronic post-surgical pain, you have to treat it aggressively. Okay, so this is one of, anyway. So shared decision making with the patient. These are the things which with the patient. A single point of contact for advice and information. Okay, advice on patient role in improving post-operative outcome. A personalized perioperative management plan for comorbidities. Okay, then for professionals, access to education and training in perioperative care, access to whole pathway guidelines rather than specialty specific guidelines. This is actually, I don't agree fully to this point, because they referred here that there should be generalized plan for all the surgeries. Yes, of course, we can have a generalized plan, but there should be a focused plan of the common surgeries, of course, in your setup. Then you can devise specific plans for that surgery and for specific age groups. Okay, so that plan will be applicable by used by the all of the people who are conducting the anesthesia, and you can even monitor or audit the outcomes. Okay, so enhanced recovery pathways, as I told you, very important. Utilization of technology solutions, virtual consultations. This is very important. Of course, this is with reference to things this was done in NHS in UK. Increase in outpatient based procedures, day surgeries. So this is very important, because if you are reducing the hospital stay, there will be less morbidity. There will be early ambulation. The chances of complications, especially with reference to embolism. Okay, DVT and embolism. So this is because they are focusing on the things which can cause more morbidity and mortality. So this is a very important thing. Then, of course, economic things, because it will reduce the hospital expenditures as well. Okay, so they are saying that day surgery to be regarded as a default surgical pathway, aiming for only 15% of all elective surgeries to be performed as inpatient. So 85 surgeries, 85% should be tried to be done as day surgery, and actually they are doing it. Of course, there will be certain exclusion and inclusion criteria in day surgery, but of course, there are so many procedures which can be done as day surgery. Okay. Optimal patient listing, right place, right time, reduce day case to inpatient conversion. Yeah, this point is that you booked it not fit, not properly screened for day case, and now patient is ending up in post-operative admission. So this is they are also trying to reduce it, reducing length of hospital stay, reduce cancellation of the day of the surgery. So actually, this is these are there was another article. I will share actually all these articles, and you can have a look of it. The basic message is that try to involve yourself in the patient management in the whatever best possible way, and like the result will be a better patient outcome. Okay. So thank you very much, all of you. Anyone wants to ask any question or any input or anything wants to add on, I will be very happy. Yes, Nawaz. Now it is you can understand this is not the pre-operative
Yeah,
evaluation.
I got it, sir. I got it about this one. But my question was, before means I was thinking because I saw this fellowship in USA was there
Yes.
perioperative medicine. After doing this, I will be just confined myself to just looking after the patient, like in assessment in the wards, like that, or I will be working in OR
No, no, no,
also,
no.
or I don't know.
A- Actually, I tell you something. That is a separate question, but I will try to answer. Actually,
Yeah.
in my
Yeah.
opinion, if anyone wants
Mm.
to have a fellowship with like because anesthesia is a diverse field. In Pakistan or
Mm.
even India, we are doing anesthesia, pain, ICU all together. But in rest part
Yes.
of the world, pain is totally separate, ICU is totally separate,
Yes.
and
Yeah.
anesthesia remains anesthesia. If you want to be a good anesthetist, I think this is the need of the hour that you should have a fellowship in perioperative medicine because this will make you a safer anesthetist. Your decision making will be better. You will have better
Mm.
control on your decisions, and of course, this will be giving us more actually respect, which unfortunately we don't get because we are only taken as a doctor for takdir, a doctor for sleeping or awakening. Okay, so there was a joke on it that doctor, there are charges for anesthesia as well. So someone answered, no, no, giving you anesthesia is free. The charges are to make you awake again. Okay, so we have to
You
come out of.
reckon?
So of course your question is valid, but I don't think so that if any place you have done this fellowship, you're not be focused only on this thing. Of course, there are certain
Mm.
specialities, or if you are on a like big, you become as you grow senior, or you are on in a position where your role is multidimensional. Of course, we focus on the specialities which we like. Okay, so it is a part of that. But in my opinion perioperative medicine fellowship is an excellent thing. So whoever get a chance should do it. Okay. So any other
Oh,
question?
okay. No,
Okay.
nothing. Well,
Okay.
this
All of you, thanks a lot.
it was a nice lecture.
Thank you.
Mhm.
Thanks a lot. And actually, I will just tell you that on this same, almost the same topic, I have done multiple sessions because the focus is the same. So focus is the better patient outcome with focused yes, just a second, I will just show you the previous discussions which I done. This is some discussions about opioid free anesthesia, and actually in this pre-operative assessment and like surgery based discussions also. But I will just let me show you what I was. Hmm. Because risk stratification is the things which you should be, because before, yes, this is actually my like main focus. I have done this topic a number of times, so you can find the previous discussions over here. The basic motto, remember that the more you get involved in the overall patient care, the better will be patient outcome. Okay. So thanks a lot, all of you, for joining. And inshallah, we will meet with some new topic. Assalamu alaikum. Bye bye.